the thing is, this is a little bit about shutting the stable door after the horse has bolted, isn't it? Because we've already got cases being detected in other geographies, in other countries, and also other parts of China.
Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today. In December 2019, the first human cases of a new coronavirus were identified in the city of Wuhan in central China. As of the 25th of January, over 1,000 cases had been identified globally, including several in Hong Kong, Thailand, Australia, France, and the United States. The death toll has reached 41 and is likely to climb further, whilst China has expanded its transport ban in efforts to contain the virus. In the UK, 14 patients have tested negative so far. Public Health England has stated that whilst it was likely that cases would be found in the UK, the risk to the UK public was low. This comes as officials attempt to trace 2,000 people who have recently arrived in the UK from Hubei province at the epicentre of the outbreak. To shed some light on what is currently known about the virus and the public health response to the outbreak is our guest today. Dr. Chris Smith is a consultant virologist at Addenbrooke's Hospital in Cambridge. He's also the host of the Naked Scientists podcast. We started off by asking exactly what do we know about the nature of this new virus?
Well, this story begins at the beginning of December 2019, and in a remote part of a seafood market in a very big city in China, Wuhan City, you see a number of people who suddenly start to get ill, and the symptoms are just like you'd see with the flu, but in some cases they get really, really, really ill. And these are people who wouldn't otherwise, except with a few possible exceptions, suddenly go down with something like this. And for a public health doctor, alarm bells start to ring when you see a whole bunch of people suddenly developing a whole bunch of very similar symptoms all at once. And that tells you there's some kind of common source. So the Chinese authorities realised that when they had tens of people, all in one geography, all presenting with this, and they were testing negative for all the usual culprits, like the flu, like adenovirus, like human coronaviruses, and they got caught with their pants down in previous years with SARS, they got nervous and they started looking much harder. And by the time January the 1st came along, they were on the phone to the World Health Organization saying, we've got an outbreak of something, it's defying all our tests, we don't know what this is, got some insights, our instincts are telling us something, but it's something novel. And now where we are later on in the month of January, what we're seeing is a big escalation, and that's not just because it's spreading, because it has been spreading, but it's because now we know what we're looking for, so people are testing, and if you go looking, you find. So now what we're going to see is how far does this thing go, what is it, how does it spread between people, and crucially, where did it come from? Because although we've got this connection to this little bit of this seafood market, what we don't know is what was in that market that was the source that then got into people.
And how much of those questions is already understood? Do we know how dangerous this virus is? Do we have any ideas about the origins of the virus in terms of it being transmitted from animals, for example?
The amazing thing about this era in virology is that it's the molecular era. Previously, when something came along, scientists would take samples and then painstakingly try and grow this stuff in the laboratory. And sometimes it would grow, sometimes it wouldn't. But it would take them decades in some cases to try and get these things so they could study them. But now we're into this era where you take a sample and it doesn't even matter if you don't know what it is. You can begin to copy the genetic information in there, and you can take all of the copies and then you just read them and say, have we seen any of this before? And any stuff that comes up that you know exactly what it is, you just chuck it away. We know what that is. Oh, look, that's interesting. We don't know what that is. We've never seen that before. And if we compare it with things we have seen before, it's got some comparative matching. It looks a bit like that. It looks a bit like that. So what they began to do was to use that strategy and realise that what was in the lungs of these people who were succumbing to this mystery illness in Wuhan City was a coronavirus. Coronavirus is a family of viruses. They're quite a big family of viruses. Each virus particle is called a coronavirus because if you see it down an electron microscope, it's a spiky, looks like a crown of thorns actually, and the spikes are the receptors that it uses to grab hold of the cells it wants to infect. And this falls into three subfamilies. There's alpha, beta and gamma. Some of these members of these families infect humans, many don't. Birds are also very often very often carriers and get infected by these things. And so they realised that they had a virus that was in the beta coronavirus group, and when they compared it on their databases, it was 90% similar to SARS, the previous thing that had appeared under similar circumstances in China, and SARS came from a bat. So that immediately makes you think, oh, wildlife or seafood market. We know there was an under-counter trade in dodgy species that shouldn't have been there. We know that often people trade things in these markets in China, that they often go out and catch stuff and trade things like bats, other exotic species. All of the ingredients were there for this to happen. And where we are now, we know what the virus is. We don't know where it came from, although we've got evidence that it seems to have homology, looks like a bat coronavirus, but also a snake coronavirus, so it may be that the two have merged in some way. We know that the mortality rate, it's about 10%, 5 to 10%, so it's not screechingly high, because another virus like this MERS-CoV has a much higher mortality rate. An avian flu has a really, really high mortality rate, like Ebola. So not in that sort of regime. We know that initially it wasn't spreading very efficiently among people, but as we look harder, we're finding more and more cases suggesting that it has been spreading, and it is spreading between people, so it is contagious. But at the moment, we're confident that it's not a really, really, really nasty virus.
And jumping to humans, what exactly does it cause in humans? What sort of symptoms?
Flu-like illness, and that's the real headache, excuse the pun, because who hasn't got a cold, bit of a sore throat, runny nose, flu-like illness at the moment? Millions of people have got a flu-like illness at the moment. So writing a case definition, have you had these symptoms, to screen out the people, really tough. So part of it is that it's lurking, it's kind of hiding in plain sight in the milieu of other things circulating at the moment, making it much harder to pull out the cases.
So in fact, there could be a lot of people infected with this virus who just aren't affected particularly severely and could be transmitting it to other people.
And there's 1.4 billion people in China, and they're about to embark on the world's biggest migration of human beings, which is the Chinese Spring Festival and New Year. And what better way is there to ferry around a virus and encourage dissemination than people carrying it all over the place on a big migration?
Although as we're speaking, there's a 35 million person kind of lockdown, including in Wuhan as well.
Yeah, but 35 million out of 1.4 billion, not very many. And the thing is, this is a little bit about shutting the stable door after the horse has bolted, isn't it? Because we've already got cases being detected in other geographies, in other countries, and also other parts of China. So this will almost certainly retard the rate at which it spreads, but it's in no way going to stop it.
So are there any ways in which we can stop it then?
No. I mean, this will go where it's going to go. The only thing we don't really know is how big the numbers are going to be, and they might be really, really high. They might be trivial. SARS was interesting. Once people jumped on it, it stopped at about 8,000 people. The measures that were put in place stopped it spreading, and it never came back. So that one was a very, very similar sort of trajectory, very similar illness, and the measures managed to stop it.
So do you think that this is a proportionate response, therefore, by the world media, by the Chinese health authorities, then to the virus, if actually all they're really doing is perhaps delaying the slightly inevitable?
Yeah, because what they're doing is buying us time. This laboratory we're sitting in hasn't got a test for this new coronavirus yet. But by next week it will have, because we've already got the primers that we're going to use to do the PCR to identify it. And so next week we're going to be rolling out the recipe, and that means we'll be testing here instead of sending samples to London to confirm the diagnosis. So the more time that you can buy, the better equipped you'll be, because you'll learn more about the virus, you learn more about how it behaves, you learn more about what it can do, you learn more about how to defend against it, and time's everything. So by slowing down the trajectory of spread, you can shift the odds more in your favour, which is what they're doing.
And following on from that, I'm quite interested, how do different groups around the world who are interested in better understanding this virus, how do you collaborate with each other? And what are the potential pitfalls with collaboration? So I know, for example, with the outbreak of Zika in 2015-16, one of the big problems was that when they were looking for potential interventions, like vaccinations for this virus or treatments, there were different groups working to different standards, so it was very difficult to compare the results that different groups got.
Well, the answer is, with things that are of international impact, then there's very good collaborations, and that's where the World Health Organization comes into its own. And they do this every year already for the flu, because the flu makes a massive annual circuit of the globe. New strains of flu emerge in one hemisphere during their winter, and they're handed on person to person, and they make a giant circuit of the globe, arriving in the opposite hemisphere in time for their winter, their flu season. And this is being monitored. There's something like 20,000 laboratories all over the world who are collecting all the time samples of the flu that are being sent in by laboratories like this one. And they're monitoring the status quo and sharing all the information. And then people can use that information and look at how the flu is changing and migrating to anticipate how it's going to change in time for the next winter in the next geography. And that informs how you make a vaccine. So actually, these sorts of measures work really well. And the flu vaccine's 75% effective in a good year, which that's pretty good odds. And so when something like Zika or like Ebola comes along, there is a mechanism for information sharing, for helping people, support, helping people to very quickly reach diagnoses, mitigation strategies and so on. And at the end of the day, we're all in it together because you've got a global problem and it needs a global solution, and this is one of them.
I'm just thinking, to what extent are countries good at almost sounding alarm bells when something turns up, or are there instances where things can kind of be brushed under the carpet, especially when time is of the essence?
Depends on the country. And there are plenty of people who are not very honest. And China, don't want to point the finger, but they're not very honest. And when SARS happened, most people don't realise, because they think SARS appeared in 2003. China knew about that for more than 6 months before they told anybody. And when they eventually did, then it really was the horse bolting after the stable door had been slammed shut. More than 8,000 people got that. 800 died. About 50 countries declared cases. Now, if they'd been more open, more honest, and more prompt to do those things, maybe the outcome would have been different. And for those 800 people, that could have been the difference between life and death, couldn't it? So it is important to be honest and to share these things, because the world we live in now is so interconnected. And most people don't realise, if you say, well, if I stopped time now and froze everything and I counted how many people there are on aeroplanes right now, how many people would it be?
In the hundreds of thousands?
It's about 1 million.
It's quite a lot.
And no city is more than 24 hours from any other. Now that's much less than the incubation period for your average disease, to be honest. So in other words, you're on the other side of the world and going about your business well before we have any chance of diagnosing you with anything. So in this day and age, with that level of risk, you're cruising for a biological bruise in there, and you've got to be open, transparent and honest. Otherwise there's going to be really big consequences.
Yeah, and I guess leading on from this, if we were to count the number of people currently, if we were to stop time and count the number of people on flights from China to the UK, should we be worried?
Well, there's is it 3 flights a week from Wuhan city to Heathrow? And the thing is that those people are documented. We know where they're coming from, we know where they're going to. Those people are going to get briefed on the flight. They're not allowed off the airplane before they've been told clearly what to do if. And there's scrutiny of those people as they come off the flight. And if you hobble off the flight looking half dead, they're going to cart you off. And because we know who sat next to who and who was on that flight, contact tracing actually becomes quite easy. And because you don't become infectious for an agent like this new coronavirus until you're symptomatic, and the incubation period is maybe 6 days, actually you've got a chance to go and grab people and find out what they're like, are they ill, are they well, and isolate them before they can become a major threat. And that's why we stopped SARS.
But this also speaks to what we were just saying, which is how important it is to get acting early, because you can imagine how after a period of time it suddenly becomes impossible to trace everyone who has interacted with somebody who might have been infected.
Yeah, but once people become symptomatic, they generally aren't party animals. So you can go and find who's mixed with whom, and your list grows quite fast. I mean, the number of people on a watch list earlier this week, when we knew there were only a few hundred cases, was thousands already. So it's a mushroom. Okay. But if you know there's a person on an aeroplane, you know what seat they're in, you know who was around them on the plane, you know who's therefore got the highest infectious input and who's at greatest risk, and you can go and focus on them. And that's what's been done in the past with things like Ebola.
And how contagious is this virus then? Could somebody go on the London Underground to a virology clinic in London and suddenly this pandemic could explode?
Yeah, we don't really know, to be honest, but based on the trajectory that's being observed at the moment, it's certainly not like measles. Measles is the king of infectious viruses, the R0, the reproductive number, which means how many people will each infected person on average infect. For measles it's 12 to 20. It's huge, very, very infectious virus, whereas flu is down in 2, 3. This virus, SARS, probably 1.5. So it's very, very low compared to measles. But that's not zero, and that could change, and it may just be an artifact of what we're seeing at the moment. Things may evolve. So I'm keeping an open mind.
Is it important that the response to outbreaks like this in the media remain proportional? I remember when the Ebola outbreak happened in America, it seemed like really hysterical the way that the media were responding. Does that help raise awareness, or is that a hindrance?
Well, if you talk to people who were in Sierra Leone, who lived there, they say that in fact there was so much misinformation that no one knew who to believe. And so that's one end of the scale. The opposite end of the scale is people looking to, juicy story. Publish a juicy story, hype, hot air, big headline, that sells newspapers, doesn't it? So there's always a tension between being faithful to the reality and then getting a good scoop. And there is a temptation to do that. Responsible journalists won't do that, but some do.
But do you feel there are enough, especially with mass media now, there are enough irresponsible journalists that even if there's reputable journalism, suddenly fear stories and grabbing headlines just take over?
Depends on the medium, doesn't it? Because the traditional press are hopefully still faithful to who they presume their readership are and their editorial code. But when you've got new kids on the electronic block who are just pushing out stories because they want you to click on their website and then go and be deluged in adverts that make them money, then they might have a slightly different approach.
At the risk of sounding slightly alarmist, is there any upper limit to how bad this epidemic or pandemic could become?
Well,
do we have any reason to believe that it couldn't be as bad as like the Spanish flu?
History repeats itself, right? And this is very similar to SARS. And SARS was gone within a year. And okay, we know it got to 8,000 people. And we know this one is probably halfway there already to that number. But I'm reassured by the fact that we know about it a lot sooner. We've learned a lot about it just in the last week. There are people now reverse engineering this virus in laboratories so they can grow it in lots of different laboratories and then make tests for it. And people are already talking about making a vaccine for it. So I think we're in quite a good place, actually. I think pretty well prepared.
And a treatment for those already infected?
Well, unfortunately, this class of viruses, there is no treatment. It's not like we can pop a pill with some penicillin in it for a sore throat, for a strep throat or something. Unfortunately, this class of viruses, there is no drug. But if we can make a vaccine, and the way they make the vaccine is they take part of the coat of the virus and they take the gene that encodes that coat, and then you just inject people with bits of DNA corresponding to that. And that DNA is taken up by various parts of the immune system, turned into that part of the virus, displays to the immune system what it looks like, and you then get an immune response. And that's what people are doing for MERS-CoV, and that works, that vaccine. So using that to inform how we approach this one, it wouldn't take very long, I wouldn't think, to make an effective vaccine against this if things did begin to look dicey.
But Chris, I read online that vaccinations are bad for you.
Did you? Where did you read that? Twitter?
Yeah. I'll be quiet now. Go ahead, George.
Yeah. But I was going to ask, on the topic of treatments, there's not necessarily a treatment out there, but can we support people in these positions who have been infected by this virus? And who exactly are we worrying about? I mean, we're sitting in Addenbrooke right now. I'm sure there are a lot of people who are immunosuppressed, who are maybe elderly, who are people who are typically really badly affected by flu.
Yeah, well, we don't know who's going to be more vulnerable. We're going to sure as hell learn that in the next couple of weeks, I would think. We'll get a much clearer idea as to who's getting it badly, and perhaps why. And also, we'll learn important things about how best to control it. How fast does it spread? How efficiently does it spread between individuals, in what sorts of contexts? And that will be really useful, because that will then enable us to make predictions about who is most at risk and how to help them.
So I think wait and see. And watch this space.
Yeah, watch this space. It's changing by the minute. You know, the story that we were treated to this morning about the status of this thing is a very different story than we're going to read as we go to bed tonight. It's completely changed. The landscape's changing so quickly.
But it certainly reassures me that people like you, Chris, are on it.
Well, I'm on talking about it. I haven't done anything about it yet, apart from talk about it. But maybe next week when we wheel out our test, I'll let you know how we get on.
Well, thank you so much for joining us.
It's a pleasure.
Thank you for listening to the Pager podcast. If you've enjoyed it, then head to Spotify or iTunes to hear more.
As ever, we'd love to hear what you think. Do leave us a review on Apple Podcasts if you have a moment, and you can also reach us via our website and our social media pages.